Yes, Dr. Joseph, you can start off your lecture. And as you are aware, I have informed Oren that the lecture is online. Oren knows on the link. You can start off with the lecture, please.
Okay, very well. Thank you, everybody, and welcome to this CME seminar. My name is Joseph. I'm broadcasting you from Caesarea, Israel, and my topic today will be lasers and skin interactions. We'll go some introduction on lasers, and initially by, of course, introducing Albert Einstein as the founder, I would say, who theorized the concept of light physics in 1917, back in the last century. The laser foundation is the basic operating principle of the laser were put forth by Charles Townes and Arthur Shellow from Bell Telephone Laboratories, USA in 1958, and the first actual laser based on a pink ruby crystal was demonstrated in 1960 by Theodore Maiman and the huge research laboratories in the US. Not surprisingly, the CO2 laser inventor came from India, from the AT&T Bell Laboratories. Chandra Kumar Nardabhai Patel was the one who invented this laser, this industrial laser, already back in 1963. The first laser foundation in medicine is attributed to Dr. Leon Goldman, who is the father of the laser in medicine, passed by in 1997. When we are talking about the electromagnetic spectrum, light is usually refers to visible light, which is electromagnetic radiation that is visible in space. Can you hear me?
Yeah, I can hear you, Dr. Oren. It's
okay.
perfectly fine.
Visible. Yeah, so light is within the electromagnetic spectrum, and it can be visualized in daily life by our senses, by the eyes. This is a triangle prism dispersing the beam of white light, which you can see here where the longer wavelength is red and the shorter wavelength is blue, gets separated and from the white source of light. Typically, when we're talking about lasers and skin interactions, two major light sources can be foreseen. The first one is a polychromatic light source, which can be dispersed by many lights of colors, as shown here. And the other one is laser, a monochromatic, non-diverge light source. Electromagnetic spectrum is light can be described in light visible and invisible, ionizing and non-ionizing. It is really energy measured by wavelength along the scale called the electromagnetic spectrum. As you can see, the different lasers are defined by the specific wavelength of light or energy that they produce. Rather than using a specific wavelength of light, intense pulse light applies a broad range light from 515 to 1200. Filters are used to determine the wavelength range. So you can see here from left to right the UV, the visible, and the infrared, denoting two different wavelengths of lasers expressed from very low, like 200 nanometer, up to 10,000 nanometer of the CO2 laser. And when you talk about the skin as the target for these lasers, one can see that the skin is very diverse, a very involved structure, and confine many structures that have different colors. And this is why we're able to aim or to introduce laser beams in different colors to interact with some biological matter that has the ability to accept those photons or electromagnetic radiations in their properties and change their behavior. For that matter, we all know of these biological chromophores, which are mainly the melanin, the oxyhemoglobin, the deoxyhemoglobin, proteins, and water. The clinical applications of laser interaction is characterized mainly to those clinical like unwanted hair, vascular lesions, acne and scars, pigmented lesions, and tattoo, skin rejuvenation of ablative and non-ablative nature, and leg veins and varicose veins. So these are the major groups And based on the experience we gained in the past 40 years or more of lasers in dermatology, we have gained more than 150 indications we can treat with lasers. What is a laser? Laser is acronym for light amplification by the stimulated emission of radiation. Basic laser components are gain medium, pump, and resonator. The gain medium is source of atoms to be excited, like Nd:YAG or holmium or YAG or argon. The pump is energy source to excite those atoms, like flash lamps, laser diodes, RF and DC type. And the resonator are an arrangement of mirrors that motivates linear stimulated emission. These are the basic laser parts. You can see here the optic cavity, the laser beam, the partially in reflecting mirrors, the power source, and the totally reflected mirror. The lasing medium are important to realize, and they are divided into three parts: gas, solid, and liquid. The gas are typically argon or krypton or CO2. The solids are Nd:YAG or diode, and the liquids are dye. The lasing medium determines the wavelength of the laser. Also, it's important to realize that we have special delivery systems to introduce the light source by using articulated arms, optical fibers, micromanipulators, focusing handpieces, or lenses. What is the photobiology of laser-skin interaction can be portrayed from this slide, which exhibit many potential targets for lasers. As you know, the laser can hit on different surface of the skin to be as shallow as few nanometer and as long as a couple millimeters into the skin to target like hair follicles or pilosebaceous units or vascular lesions, microvascular lesions, or other targets that have special structures such as sweat glands as well. The difference between the type of lights, laser versus IPL or intense pulse light, can be seen here. The laser is monochromatic, is coherent, and collimated light source, no divergent, whereas the IPL is a broad spectrum with many type of lights, to be red, yellow, green, purple, blue, and it's non-coherent. Okay, it's chaotic when it comes to the surrounding, and it's a non-collimated. One can also see here that you can block the IPL laser or light by using different type of filters to emit to the skin special lights in 650 to 950, from 420 to 950, or from 700 to 950 nanometer by using special filters. So lasers are devices that produce intense beams of light which are monochromatic, coherent, and highly collimated. The wavelength is a color of laser light which is extremely pure when compared to other sources of light, and all the photons energy that makes up the laser beam have a fixed phase relationships with respect to another. Light from a laser typically has very low divergence. Because of these properties, lasers are used in a wide variety of applications in procedural dermatology. When we're talking about skin interactions, one can sense that light interaction with tissue can be transmitted, reflected, refracted, scattered, or, which is the most important, absorbed. Absorbed light can cause heat, chemical conformational changes, fluorescence, or phospholuminescence. These are the four types pathway of light interaction you're all familiar with. First is the reflection. Second one is the transmission. Third, which is one of the most important, is scattering. And the final one is the absorption. Absorption and excitation are the must for all photobiological effect. Energy is proportional to the frequency and inversely proportional to the wavelength. For example, 532 nanometer photons, is twice as energetic as 1,400 nanometer photons. When absorption occurs, the photons loses its energy to an atom or molecule known as chromophore. Skin interactions can be divided in four major events: thermal, mechanical, photoablative, and photodynamic. The absorption spectra is a major skin chromophore dominant laser tissue interaction in dermatology. The absorption coefficients, which is mu A, is the probability per unit path length that a photon or particular wavelength will be absorbed. And this is the example of biological tissue I just earlier in my slide, showing the major ones that creates us the map where we can align the appropriate laser to be absorbed in specific chromophores such as the melanin, hemoglobin, proteins, or water. These are examples of the different laser in their main chromophores, which you can see that the KTP and the pulse dye laser, the hemoglobin and melanin, the major ones, in their 532 and 595. The ruby, alex, and diode, and Nd:YAG, their main chromophore is melanin, whereas the erbium glass and the erbium YAG and CO2, their major chromophore is water. Besides of their absorption, which is essential, of course, laser can penetrate in a different way into the skin based on their wavelength. So wavelength that are short, penetration will be short, whereas larger wavelength will most probably will bring deeper penetration. And this is an example of laser penetration in tissue, describing the optical penetration on the y-axis and the wavelength on the x-axis. And you can see that the 1064 peaked the highest, and it's well known that 1064 Nd:YAG is the laser that penetrates the deepest into the skin and gives us the ability to interact with water, which is 70% out of the body contain water. And of course, when we want to go as shallow, we want to go into wavelength that are in 2,900 nanometer where erbium and 10,000 where the CO2 is. And these are just examples of those biological chromophores and the cross peaks with their respective lasers expressed here in nanometer. So the effect is based on the interaction of light wavelength and tissue chromophores that brings us the ability to change or to make the necessary damage on the tissue. Here is an example of the curve of the oxyhemoglobin. And when you zoom into it, you can see that there is a discrepancy or disparity between the oxyhemoglobin curve and the deoxyhemoglobin curve. Both have different feature, different characteristic of their absorption of light. Whereas you can see two peaks on red on the 540 and the 570 nanometer, and at the 660, okay, we have the baseline, actually almost no absorption by the oxyhemoglobin. This is the light which we want to target into the red blood cells, into the body, when we introduce different lasers that absorb the oxyhemoglobin, such as 532 or 540 or 570 nanometer or 595 or 585. These are the wavelength which will be used for targeting these red blood cells or in the blood. The problem is, of course, getting into those structures, because these are sometimes like deep into the skin, and sometimes they're large, and we need to have the right laser with the right energy to make the right damage. So these are just some examples that you're all familiar with from the clinical point of view, some imperfections of vascular targets that we want to aim and use with lasers, starting with the, of course, pulse dye laser or Nd:YAGs or KTP. And these are other type of imperfections, pigmented lesions, which we want to target with lasers that are more sensitive to melanin. Okay, water is not to be forgotten, is a very important chromophore, biological chromophore, which we use away from the regular visible light. We are going to the right to 2,900 to 9,000 nanometer up to 10,000 nanometer, where we want to make a different type of damage to the skin. to the biological skin, and we'll see it. What are the parameters of lasers we typically see? Those are the basic laser parameters, such as wavelength expressed in nanometer, pulse duration expressed in milliseconds or picoseconds or femtoseconds, the fluence, which is expressed in joules per centimeter square, and spot size, which is in millimeter. Energy is measured in joules, and the amount of energy delivered per unit area is fluence, is expressed in joules per centimeter square. The rate of energy delivered is called power, measured in watts. 1 watt, for example, is 1 joules per second. The power delivered per unit area is called the irradiance or power density, which is expressed in watts per centimeter square. So these are the parameters: wavelengths, which penetrates to the target, which is absorbed by the target. Pulse width is the short pulse of the treatments, and this is actually the window time by which we introduce the laser energy into the target. So we have a short pulse and we have longer pulses, depend on the size of the target and its level of residency. Fluence is adequate and appropriate pulse width to have clinical results. So fluence is one of the most important parameter variables we want to aim to be exactly, not to do overdoing or make much harm to the tissue. Spot size, large enough to adequate penetration and speed. These spot sizes are varied among many lasers, can be from 1 millimeter spot up to 10 millimeter spot. Fluence is a measure of rate of energy delivered per unit area and is measured in joules. As the fluence increases, so does the destructive force of the laser. The pulse duration is simply how long it takes the laser pulse to deliver its energy. In general, the longer it takes to deliver the laser energy, the more gently and more uniform the target structure will be heated. So this is just an example of the spot size we just spoke. On the left, small spot size. On the right, large spot size. Spot size, the larger spots less effective by scattering than smaller spots. So the larger the spot size, you have less scattering and more of chances that the photons will reach the target deeper. Target size is also a matter. Small heat capacity for small targets, which are heat fast but lose the heat very quickly, whereas large targets slow to heat but also slow to cool down. We have all lasers are equipped with distance gauges. Distance gauges are often used to set the focal lengths of the laser beam, allowing the focusing lens to deliver its laser energy directly to the focal plane and the spot of the target. These are an example of focusing lenses enable the delivery of laser energy to the correct tissue depth. You can see here a focus lens, okay, on the tissue, on the level of the tissue on the left, and defocused on the right. We can use these different distances to make a different impact or thermal effect on the skin. What about laser skin interactions, major issues? As mentioned earlier, we have laser has 3 major interactions: thermal, mechanical, and photochemical. Thermal denotes to coagulation and vaporization, which is based on selective photothermolysis. Mechanical is the node to cavitation and some shock waves, and photochemical denotes to some photoexcitations, biological matters that we introduce, such as ALA or PDT. Contribute to our discussion today, of course, is the legend Professor Dr. Rox Anderson, who in 1983 introduced selective photothermolysis theory into the science, and ever since then, laser became a must in dermatology. What is selective photothermolysis is that it described a theory which revolutionized laser therapy by explaining the method of producing localized tissue damage and sparing the surrounding tissue. For selective photothermolysis, we need to introduce three major variables in lasers. One is the wavelength, the other one is the exposure duration, which is the pulse duration, and the third one is the amount of energy. So selective photothermolysis is basically a selective or discriminative process involving light photons, of course, involves heat production, okay, and involves some damage. All these four variables must be introduced and considered in our lasers, and that's the reason why we have so many different lasers that are capable to target diverse types of lasers of skin imperfections. These variables are in proportional to what we call thermal relaxation time, or to the diameter in square of the target. So the thermal relaxation time is the amount of time it takes for a target to cool to a certain percentage of its peak temperature. Large volume requires longer times than smaller volumes to cool. These are some thermal relaxation time parameters tables that we can see looking at the chromophores from the left, such as the 2 ink particles, which are very small in diameter, and so is the thermal relaxation time, which is about 10 nanoseconds, and the typical laser pulse duration adhere for the same thermal relaxation time. If you're looking, on the other hand, on much larger structures, such as the terminal hair follicle, which is 300 microns in diameter, we can see that the thermal relaxation time is much greater, is 10 times greater, or even more, when compared to the tattoo. And that's the reason why our typical laser pulse durations are, we use pulse durations in the domain of 3 to 100 milliseconds. And leg veins, diameter is 1 millimeter. These are large diameters, and we need to have typical laser pulse durations of at least 45, 60, or even 100 milliseconds, or up to 0.1 second. Thermal effect of laser in the skin are important consideration when we come to understand laser skin interactions. It can go from 37 degrees centigrade from body temperature and can cause hyperthermia, coagulation, ablation, and charring and melting. In this slide, we consider different skin interactions, thermal events that may be produced by a laser. It can be vaporized tissue at 100 degrees or more temperature. It can be irreversible thermal damage, coagulative necrosis, if the temperature being sustained for 50 degrees centigrade for quite longer period of time. Or it can be irreversible thermal damage, less than 50 degrees centigrade. And byproducts of all these thermal events, we can have a thermal diffusion or non-specific thermal effect attributed or alluded to those thermal effect we're producing on the surface of the skin. These all lasers, of course, should be considered all the skin types, because one of the first limitations to the target of all the skin targets we're aiming is to overcome the skin barrier color, either to be light color or medium color, or of course black or Afro-American color. These are all important considerations when we are using a laser. Cooling is also an important variable when we deal with lasers. I just mentioned in one slide, it reduces the risk of epidermal damage, it increases maximum tolerated fluence, and it serves as anesthetics. These are the two major lasers we're all familiar with in procedural dermatology, the CO2 and the erbium. And these are comparison of both lasers. You can see that the erbium skin interaction compared to the CO2 is distinct, is quite different in the size, in the size of the damage to the right, which ablation is the prominent event on this laser, and only a very small reversible thermal damage is thereafter. Whereas on the left, the CO2 occupies a relatively smaller amount, 1/3 of the total damage is attributed to ablation, and the rest is attributed to carbonization, coagulation, reversible thermal damage. So the CO2 is a much aggressive laser when introduced to the skin, whereas erbium is more predictable. And here, these are normal appearance of histology of the skin surface. And you can see that the starting corneum and epidermis are the layers we need to overcome when we introduce a laser. These are very thin layers. However, they must be considered in all aspects of using lasers. And deeper into the skin, we see that in order to introduce laser into the skin, we need to be there at least 1, 2, 3, 4 millimeter, depends what the target is. The biophysical effect of laser on the skin today can be divided into 4 major forms: ablation resurfacing, bulk ablation, superficial fractional ablative resurfacing, non-ablative fractional resurfacing, and ablative fractional resurfacing. The fractional resurfacing is ablative and non-ablative is a novel variation on the theory of selective photothermolysis, whereas in the microscopic treatment zones, MTZs of controlled width, depth, and densities are created. These controlled microscopic zones of thermal heating and tissue damage are surrounded by spread areas of visible epidermis-dermis that allows for a rapid repair of microscopic treatment zones. This is an example of 2 different effect of light laser, full ablation on the left and fractional ablative on the right. And you can see that the fractional ablative, of course, has different circumstances or outcomes on the surface of the skin. And today's more and more non-ablative fractional lasers becoming to play a major role in aesthetic dermatology. These are just a nice diagram I got from Dr. Christine Derricks, one of the founders of laser hair removal back in 1995. And here is a bulk ablation on the top versus a localized ablation or fractionated laser, denote for ablative zones and coagulative zones that we're all familiar with, our new era of lasers that are available in CO2 and erbium and 1540 and Q-switch laser, etc. So these are histological characteristics of evaporation, necrosis, and thermal effect of a single pixelated or fractionated zones created by a fractional ablative laser, which was the CO2. And here is another example of a single fractional erbium laser damage on the skin, evaporation of the entire epidermis layer of the skin with some secondary thermal effect deeper into the dermis. And this is an example, a close-up look of fractionated ablative laser, CO2 laser. And these are the nature of the skin damage is based on the wavelength we're using, either 2940 or 1064 or 2600 nanometer. And also the pulse duration may play a role. The beam characteristics and the tissue properties all contribute to the final appearance of the damage we want to create on certain event or indication. What Alma fractional ablation and non-ablative lasers today are on those systems? The Harmony, the iPixel erbium, the iPixel CO2, the iPixel radiofrequency, all are fractionated lasers or modalities we can use in procedural dermatology. And in addition, we can introduce Nd:YAG 1064, Nd:YAG 1320, and 1064 nanometer Q-switch as a non-ablative fractional systems to treat many conditions. This is just an example of our handpiece that we mount on the articulated arm that allows us to do a fractionation iPixel CO2. And this is the erbium iPixel tip that allows us to do fractionation or ablative fractionation procedures. So, and these are the type of families of laser I just introduced. These are handpieces, very elegant, characterized by tips that you can replace and change the characteristics when needed for different indications. So in dermatologic laser, one can see a host of lasers on the left, from intense pulse light to KTP to Q-switch to flash pulse laser and other diode and Q-switch Nd:YAG and long pulse Nd:YAG. All these armamentarium of laser we at Alma have the ability to treat all sort of many applications: vascular lesions, tattoo removals, acne lesions, photoappellations, and other major skin imperfections with our systems. Of course, each one of you should be aware of the different mechanism of each laser and its specific parameters that are being designed to treat the different indications you encounter in your daily activities in your office. Thank you for your time and attention. Okay, thank you.
Yeah, we are very happy that we invited you because most of us talk about medical applications of lasers, but the basic sciences you are using very, very well. I asked my co-chair for the notes and I'm not going to hear of your thoughts on it.
Well,
and also the pulse, the short pulse, long pulse for the hair and rosacea, and also the long pulse for the power density, very important. Those things you covered very nicely. And also the nice comparison for the effect of CO2 and erbium was given. And also the fractional, full ablative and fractional ablations, those things are very clear. It was very useful to our postgraduates. And skin types also you clearly mentioned about it, from the type 1 to type 4 and 5 also. And here we have small doubts about the thing. And your experience in treatment of melasma with laser. Can you share your experience, sir?
Dr. Joseph, we would like to know your experience, thoughts on treating melasma with lasers.
Replacing the erbium YAG, which was found to be, not as good. So in today's practice, we at Alma recommend to use our clear lift or Q-switch laser with low power density, low fluence approach for melasma. Of course, depends. Typically, we're talking about junctional melasma or dermal melasma, whereas the more superficial melasma can be treated as well, but it can be approached with either IPL or similar. So the approach, this is what we advocate today, using our Q-switch laser, low power density capability.
And your experience in dermal melasma, response to laser, how much percentage is clearing?
I couldn't hear you well. Can you repeat your question?
What's your experience regarding the usage of laser in dermal melasma? How much percentage of people respond in your cases?
Well, the rate of response is not high. Of course, it requires multiple treatments. Okay, I would say about 50% respond well, and there is a shading off, or I would say migration of melanocytes and melanosomes from the area, and the question is also how long does it last. So recurrence or relapse might be a problem. But typically, we see improvement after 4 to 6 treatments with our Q-switch laser modality.
And your experience in hair removal in type 3 and type 4 skin.
Okay, can you hear me now?
Yeah, I
Yeah.
can hear you now.
Your experience in type 3 skin type, hair removal, how much it is responsive? Our dark skin, especially Asian skin.
Yeah, we are using, of course, our SHR mode, diode SHR mode, and we have, more than 70% hair reduction after 6 treatments in Indian skin type.
No, one thing is, Dr. Joseph, one thing is in India we prefer, most of the Indians, if you see the laser pattern, most of them would have a long pulsed NDAC because long pulsed NDAC is safer for the Asian skin types, which is the darker skin type. The diode with the SHR mode of late is making inroads. So which would be a better bet, the diode or the long pulsed NDAC from your experience for the darker skin types?
Well, when you look at the literature and you follow up the Indian skin in particular, I know you and Indian are keen or adoption of the 1064 nanometer laser. Based on the literature that we see, the diode is superior to the 1064 nanometer laser in general in photoappellation. I must agree that I don't have enough clinical data to share on the 1064 laser with Alma's laser on photoappellation. I do have more experience with diode for the SHR mode. Of course, the 1064, although it penetrates deeper and can hit, the hair follicle to a greater extent, of course, one of the problem is that it lacks the absorption in melanin. This is an issue. The SHR promote that or solve that to some extent, and that's the reason why we are more keen to advocate the SHR, the 810 nanometer for treatment of darker skin types like Indian skin type.
Yes, Dr. Joseph, I 100% agree with this view. The diode is better than the 1064 NDAC. Here also we are also failing. It takes more sittings with the NDAC and it is less sittings with the diode. What about your experience in Becker's Nevis?
Okay.
Response.
Baker's Nevis, typically, it's also stubborn, resilient pigmentation. The approach is typically to use Q-switch laser, and some IPLs just for the hair, if there is involvement of hair, of course. So these are all multiple treatments that should be done for this type of lesion. And typically we see shading, quite nice shading off. It depends on, of course, whether it's large or smaller, but it's not easy to clear it altogether, of course.
Thank you once again, Dr. Joseph. We are going to conclude.